the first 6 months of the COVID-19 pandemic, South Korea traced and contained outbreaks without a single national lockdown. Its death rate per million in 2020 was among the lowest in the OECD, according to Our World in Data. How? The answer is not just mass or discipline. It is a database that had been quietly running for decades, holding the medical records of nearly every person in the country. 50 million people, one system. The question that follows is simple but uncomfortable. What does a government have to know about you to keep you alive? The infrastructure behind Korea's response was built on the National Health Insurance Service, which covers approximately 98% of the population, according to the NHIS itself. That near-universal coverage meant that almost every doctor visit, prescription, and hospital admission was recorded in one place. By early February 2020, Korea's Disease Control Authority, the KDCA, was cross-referencing patient travel histories, credit card transactions, and mobile location data to map infections in real time. Within 10 days of the first confirmed case cluster, the country had tested over 65,000 people, a scale most nations would not reach for months. The government's contact tracing app published exposure routes online to the minute, and the Korea Centers for Disease Control reported keeping average contact tracing turnaround under 24 hours throughout the first wave. South Korea recorded fewer than 300 COVID deaths through the end of May 2020, compared to over 40,000 in the United Kingdom over the same period, as reported by Johns Hopkins University's Coronavirus Resource Center. This system did not appear overnight. Korea built it in direct response to 2 earlier crises. The 2003 SARS outbreak exposed how fragmented hospital records made outbreak mapping nearly impossible. Then in 2015, a MERS outbreak killed 38 people and infected nearly 180, partly because hospitals could not quickly share patient movement data. The National Assembly passed a revised Infectious Disease Control and Prevention Act that same year, giving health authorities sweeping powers to collect location, financial, and medical data during declared public health emergencies. The NHIS had already been digitizing claims data since the 1990s, so by 2020, the infrastructure was mature. Korea also created a system called the Disease Outbreak Response System, known as DERS, which allowed authorities to pull data from 14 government agencies simultaneously: immigration, telecom, credit card companies, and public transit, all under a single emergency legal framework. It was, in effect, a surveillance architecture that had been legally authorized and technically prepared long before the virus arrived. The cost of this system was borne by ordinary people who were never asked. When the KDCA published detailed exposure maps during COVID, listing the exact times and locations visited by infected individuals, some Koreans were identified by neighbors even without their names appearing. A 2020 study published in the journal PLOS ONE found that Korean citizens expressed high trust in the government's data use, but significant concern about social stigma caused by exposure disclosures. Human rights organizations, including Amnesty International Korea, raised alarms about the lack of judicial oversight when authorities accessed private telecom and financial records. The Personal Information Protection Commission has since tightened some rules, but critics note that the Emergency Powers Clause remains broad. There is a deeper trade-off here that goes beyond Korea. When a health system is efficient precisely because it knows everything, the line between a safety net and a surveillance net becomes very thin. Korea's health data system is not a uniquely Korean story. It is a preview of a choice that every modern society will face. The countries that manage COVID best, Korea, Taiwan, Singapore, all had pre-built infrastructure for sharing health data at scale. The countries that struggled most were often those where data privacy protections, though well-intentioned, prevented the rapid information flows that containment requires. The World Health Organization has since cited Korea's integrated data response as a model for pandemic preparedness planning. But a model is not a blueprint. The question is not whether to build such systems, but who governs them, who audits them, and what happens to the data after the emergency ends. Korea is still working out those answers. So is the rest of the world.